years, and the privilege of being able to work very closely with Dr. Wones and Dr. Diaz and a couple of the other doctors here in growing this network. The network has been out for about the last year. I, this last week, had the privilege of going to India to speak at the Indian Spine Society Summit. And during that talk, I spoke in front of 500 Indian doctors from India as well as internationally that came there. I was the first female that had ever been to the conference in the last 25 years. And I was, of course, the only female there. It was a humbling experience for me, not just because I tripped going on the stage. and one of the doctors that I had gotten to know joked with me, we don't wear heels in India. But anyway, but also because being able to be exposed to the orphanages in India and the medical conditions, the private hospitals as well as the public hospitals there, and being able to see the spine surgeries, a very eye-opening experience for me, and very thankful that I'm from the United States, but also very thankful to be exposed to such a culture which was very humble and gracious as India. I opened the talk by saying that Gandhi said something that I always respected when I studied him while I was growing up, and he said, "It is as important to cooperate with people that are good as it is to not cooperate with people that are evil." I believe that. And the doctors that have developed NOC2 believe that as well. This is a group that was founded on the following principles. We've been talking today about all the different things that are happening in healthcare and the way the government and the way the payer groups and the way industry and a variety of factors are causing a disarray, basically, in the medical conditions in the United States. Everyone's talking about how do we collaborate, how do we join together to get to the common goal, which is obviously the patients. Well, about a year and a half ago, I put together, with the help of some of the doctors in the room and some of the thought leaders in the United States, business plans which focus around doing just that. The goal, obviously, is collaboration, but how do you get there? Really, the only way you can get there is through evidence-based medicine and through synergetic efforts where you do cooperate together and you don't just have one force looking at something one way and the other looking at it another way. In the beginning of this network, there were very few people that believed we could do this. I still remember sitting in Fernando Diaz's office, and right away, he was very, very supportive. He is one of our board of directors, as is Dr. Wones, on some of our committees and some of our groups. And he's the medical director of one of our biggest healthcare groups. Because of that, he saw right away that if we did not put together a group of doctors that were able to work together to find a solution for patients in the United States, that there was no way that we were going to come to a conclusion that was going to be profitable for anyone. And when I say profitable, I do not mean just monetarily, but I mean in healthcare as a whole and how we are treating patients as the leaders in healthcare. So that's what we've done. We've created, through these founding principles, a group, like Dr. Wong said, almost 400 doctors that are joined together to do these things through the evidence-based research. Where do network groups come from? In my background, I actually had the opportunity in graduate school to study a lot about business in healthcare. I spent 2 years really trying to determine where is healthcare going to go, and then as I went on to my PhD, I focused on the evidence-based medicine. When I got out, I worked for NIH, and then I quickly went on to work with the biotech and the pharma companies. These network groups have been formed for about the last 10 to 15 years, very, very successfully. Has anyone in the group heard of USO or ION or P4? USO sold, US Oncology sold, if you all want to ever Google it, look it up, it sold about 2 months ago for $2.5 billion to AmerisourceBergen. P4 sold to Cardinal for $520 million about 9 months ago. These groups were not formed with the purpose of making money. They were formed with the purpose of integrating doctors so they could be a force to go to payer groups, to go to the government and to organize as doctors so they would have a voice. That's what they were forming. While they were forming, however, they were able to create ancillary businesses around this vehicle that would help the doctors continue to do business in different areas in medicine. These are groups that I've worked with in one way or another, and that's one of the ways that we, as the spine doctors, as well as the leadership of this group, were able to build the business plans for NOC2. So how did we respond, and why are we here? I know we've been talking about this, but really our solution is to collaborate and to cross-pollinate. The answer to that is data. But what has happened in the government and with payer groups and with industry is there's a lot of data, and no one knows exactly what to do with the data. The only way you can do something effectively is, and to improve the patient care, is to get all of those groups together. NOC2 spends a lot of time on panels with the government and discussions with the payer groups, not just with the doctors. That's one of the founding principles of the group. So what are the benefits to the doctors? We started with a core group of doctors, about 60 to 75, and then we expanded really rapidly. I want to tell you, during probably the first 6 months, like I said in the beginning, doctors did not understand what we were doing. They didn't think it was possible to create an integration of orthopedic surgeons and neurosurgeons throughout the United States. The concept they didn't really understand, but the key people that started this, your founders, were the ones that put this out throughout the United States to their peers and really grew this group. So what do we do in the group? Really what we do is we're able to provide education, we're able to provide clinical studies, we're able to provide guidelines and direction to the government and payer groups. We also are very involved in the regulatory process. All of our doctors are involved in different ways, and then the leadership of our group has also stepped in to be very involved as well. One of the things that we received a lot of criticism about in the beginning was accepting any kind of industry funding. One of the arguments that I had was, in order for this group to work effectively together, you have to bring industry on board. You can't just work with the government, you can't just work with the payer groups, you can't just work with the doctors. You have got to at least bring industry to the table. So what we have done is kind of a hybrid model. We have industry that is funding projects. We now have the government that is funding a project. There's a $12 million grant that is actually being rolled over to our group in the state of Washington. It started with a project called the Scope Project, and we've been asked to be integrated in and roll it out nationwide. We are also working with the payer groups on a couple of grants. So we have decided to, like I said, integrate all the groups together in an effort to collaborate and join forces. You cannot get rid of industry. If you get rid of industry, you get rid of innovation. We had some of our core founders that said, we just want industry out. So what we decided to do, like I said, is to integrate everything in. We do have projects, though, that we have not allowed industry to be involved in, and we are rolling out as we speak in the United States and as well as internationally, that will look at cost efficacy studies as well as the most efficient way to practice medicine, and we are not accepting any kind of industry sponsorship on those. This is why, though, if you look at the other column, this is why industry and government come to NOC2. We do have a lot to offer. If you really look at it, doctors have the knowledge, they have the experience. You are the thought leaders. You are the ones that are training patients. No one else is doing that. So really, industry, government, and payer groups should pay for that data. They should pay for that access. They should pay for your voice. And the only way you can get them to do that, though, is to really unify as a group and get them to understand that you've come to a table as a unified force. You guys don't have a union. So this is a way to create a loose union where you're able to do that. And I can tell you, and I'm not sure why, this is the truth, but I'm not sure why this is the case. But you take people like Dr. Wells, you take people like Dr. Diaz and Dr. Shin, a lot of the doctors that are in this room that work with our group, they have been very effective at getting industry and the government in different areas to support this network that they have created. Very, very effective in doing that. So I have people say, are you sure this is compliant with the government? Our inside and outside counsel, his name is Barry Alexander. He is over the American Healthcare Bar Association. We are the only ones that he is accepting as the inside counsel at this time because he has that appointment for the next 3 years. He works for the OIG, Medicare, Medicaid as a representative for the American Healthcare Bar Association, and he is our inside and outside counsel. We really, the key to everything though is documentation and evidence-based medicine, the data collection, and making sure that we are working in the most streamlined, effective way with the doctors that are involved. This is our presence. It needs to be updated. We are actually now in 40 of the states. And also, as you heard, we almost have 400 members at this time. So where are we going now? We are rolling this out internationally. This has happened in the last couple of months. We started with Japan, and then we went into India. We are going into 6 different countries this year. And with the purpose of making sure that we are doing data collecting and evidence-based medicine, not just in the United States, but also internationally, and being able to pull those resources so that we can get all of that information out there. So, people ask me, well, what are you going to do? You're just going to do a spine network? No. In the original business plan, the spine network was one of the pieces. The other pieces to this are as follows: C3, which is a group of all other specialties, not just spine. NRIOM, which is a CRO that does research. My Life Patient Program. My Life Patient Program is a patient program which is like Facebook for doctors and patients. It integrates doctors to the patients. It will go live in the next couple of months. We have already done patient programs, and we've done field-based studies to see if this works in the Southeast United States. It has been very, very effective. It will provide doctors and patients with a resource to connect to each other and to have constant feedback. And that has gone through legal as well. My Life Patient Program is connected to C3 and NOC2. All of that is intellectual property of those 2 groups. MedTech Specialist is an EMR piece and an IT piece, and a patient management piece, practice management piece. It originally came from MHSI, and now it's being rolled out through the United States and then internationally. It will connect to the patient registry and all the doctors in the network. MedPath is a consultant piece for doctors, and basically it just represents the doctors in our network. Objectives of NRIM, really all of it does is a typical clinical research organization where it conducts research. The only reason it's not under NOC2 and C3 is you have to have firewalls between all of them, so we had to set up a separate entity so that we could do this. When we set up NRIM, we also set up 2 foundations. One was called NOC2 Foundation, one was called C3 Foundation. They are connected to NOC2 and C3 as well. Those are our nonprofit branches where we get educational grants from the government and from industry. And we had to do that so, well, you guys know this, in case there were things that you had to go through a nonprofit, we made sure that we connected that to our for-profit branch. So what kind of research methods? We do anything that you would do in-house in an industry or the government or payer groups. We do everything. We're a typical clinical research organization like Sarah Cannon. There's a variety of those out there. If you run these right, which Lisa Tayo is the one running this group, she's very, very good. They are hugely successful. The main part of this, and I know you guys know this, is a patient registry, making sure that we get all of the data. And when we do get all the data, we do represent the doctors. We sell that. We do not give that data away. We make sure any doctor that is in our network, before we give anything away, that we have their permission. So again, this just talks about the partnership, the collaboration of the data. What is our goal? Our goal is pathways, strategic guidelines. That's what the government's trying to do. I sit here and I listen to all the talks with the doctors, and when I go to the government panels, I'm on 2 different panels. One was appointed by Obama's administration, and one was Newt Gingrich's group. And the talks are totally different than the ones that I hear here. They want to take data and develop strategic guidelines without any doctor involvement. So, and I am the one advocating on behalf of the doctors, but I really believe that unless doctors step up and there's a voice in these constant meetings, they're going to make these decisions without any doctor input.